Hello, good evening, everyone. Once again, we are really sorry for being very late. We know it. We understand that we are really sorry about this, but of course, we are trying to fix it, and we were trying our best to be here with you. As you can see, Dr. Tsakos is actually right here. We are ready. Hello, Dr. Tsakos. Thank you for your patience, and I'm glad that we were able to fix it, and we are here with everyone right now. I hope that you are ready to talk about uterine fibroids, myomas, all the malformations, because this is our topic tonight. And I don't want to wait any longer. We are really waiting for you to hear what you have prepared for us tonight. So thanks everyone again. Sincerely apology. We are sincerely sorry, but I'm glad that you are still here with us. And now I think it's best to start. Dr. Tsakos, are you ready to discuss our topic tonight?
Yeah. Hello, good evening. It was my fault. My team and I, especially Dr. Manos, said yes. My research fellow prepared an amazing presentation. So unfortunately, it wouldn't upload. So that was the issue. I'm very sorry. So we have it on at the moment. So
it's right here.
Fantastic. So it's 33 slides. I will go through them as quickly as I can. The uterus is very important for implantation and very important for pregnancy. And this organ is often dismissed when we investigate. And it's often considered to be okay, even if it's not okay. And what I'm trying to touch upon tonight is ways to diagnose problems, how we understand those issues, those challenges regarding the uterus, and of course, what is the best way to manage them. So an overview of uterine fibroids and other malformations. What are the clinical manifestations? What's the effect on fertility? And what treatments should we be offering our patients? So the overview. Fibroids, also known as leiomyomas, myomas, etc. They're benign, usually tumors, although not always. Around 1 in 500 of myomas are malignant, so we have to be aware of that. And they're typically round, and they can be found in various areas of the uterus. Sometimes they're within the uterine cavity, some other times are within the myometrium, some other times they're on the external part of the uterus, and some other times they could be very close to the ovary, or they could present as ovarian cysts. How common are they? Very common, very common. Around 80% of women may have a small myoma. Around 50% of women may have symptoms. So women with myomas, I have some gross photographs and pictures from surgery, and especially robotic and laparoscopic surgery, with massive myomas that women were not very aware of. And if they were just complaining of mild discomfort when they actually had myomas the size of a football in their abdomen. About 30% of women with myoma need treatment, and up to 60% of those may need to have treatment again. So very common. So these are the different types. And of course, mapping the myomas is very important. We're very often, as I said before, my team and I were very interested, and we're actually specialized in the management of myomas, both in the context of fertility, but also in the context of general female health. So myomas could be a trouble even for women who have completed their families, and even for women after menopause. So this is something we have to be fully aware of, that myomas are managed in a different way, depending not only on their actual size and location, but also mainly depending on who they affect and what symptoms they produce. Right. So the risk factors for myoma include obesity, family history, not having children, and early menstruation, onset of menstruation, and late menopause. Now, this is a different type of malformation. So the topic tonight is anomalies, abnormalities of the uterus. So these are congenital uterine malformations. This is also fairly common. We often see this in the context of investigating women for fertility issues. And of course, the challenge is the treatment, depending on the type. How common are they? About 1 in 20 women have some sort of anomaly. However, these anomalies are very common in women with infertility. So it's very important that prior to embarking on any fertility treatment, it's very important to diagnose those anomalies. And if we can't confidently diagnose uterine anomalies via scanning, then some other means of imaging are important, and more particular, the use of either saline or foam, hysterosalpingogram, or even the standard X-ray, HSG. Now, what I would like to point out here is that although the overall prevalence is only 1 in 20, so in the general population, the prevalence in women with fertility is higher, and the prevalence of uterine anomalies in women with miscarriages and infertility is even higher. So we have to be aware of that, and we have to thoroughly investigate those patients prior to embarking on just another IVF, for example. These are the types of the anomaly. I'm not going to go into very much detail. This is the arcuate uterus, which is fairly common. This is a normal uterus, the bicornuate uterus, uterus didelphys, and the septate uterus, which is the commonest, and thankfully an anomaly that can be almost 100% treated by hysteroscopy. How do they present? I mean, fibroids, they may present with pain, infertility, heavy bleeding, or other symptoms, pressure symptoms from various organs. We can see the symptoms here, although we can have asymptomatic fibroids and congenital anomalies. Usually we have some sort of manifestation that makes us suspicious of those conditions. What is the effect of fibroids and congenital anomalies on fertility? There's a no negative effect. I mean, I have to stress that. There's no doubt that fibroids, regardless of their size, even smaller fibroids, they affect fertility. Of course, the question is, how do we deal with them? How do we deal with a small, say, 2.5 centimeter fibroid, which is in the wall of the uterus and doesn't destroy the cavity in a woman with infertility? Do we remove it, or do we just observe it? This has to be an individual decision. Generally, we're conservative. However, how conservative can we be for fibroids within the uterine cavity, or with fibroids that grow faster, or with fibroids that produce symptoms, or with fibroids, even small or medium-sized fibroids on women with failed IVFs or with miscarriages? I think here, what is very important is to individually counsel the patients. And of course, prior to performing this counseling, we need to carefully assess and map out those fibroids by means of a very specialized ultrasound scan, maybe a 3D scan or Doppler studies, usually together with MRI scanning, and definitely hysteroscopy, and also sometimes laparoscopy as well, in order to assess. So it's not a very easy answer most of the time. It's very well known that fibroids, uterine fibroids, negatively affect fertility. And we have a study, my team and I, at the moment, which is under review, a publication on the effect of fibroids, and in particular of the robotic and laparoscopic management of fibroids, and how does that affect fertility. And equally, there are studies that a uterine septum or a congenital uterine anomaly may affect fertility, and it's very important to address those issues. Again, lots of research, very well known. So my suggestion is do not undergo IVF unless you've made sure that your uterine cavity is normal, that your uterine wall is normal, that you have no fibroids, and so forth. If there's any doubt, proceed with further investigations by means of 3D ultrasound scan and an MRI scan. Because the negative effect, I mean, I wouldn't like my patients, definitely I wouldn't like anyone to undergo miscarriages or repeated failed IVFs before they discover that they have a uterine anomaly. We might as well discover that before we start expensive and complicated treatments. Okay, what is the treatment of those conditions, of those anomalies? I will keep my presentation short so that I can answer questions. So watch and wait is one treatment option. Non-invasive medical treatment is another option. Minimally invasive options, which include the gold standard, which is laparoscopy, hysteroscopy, and robotic, but also the radiofrequency ablation of myomas could also be the solution. And of course, other solutions like traditional surgery or endovascular embolization could be on the table of options, although it is not really indicated or suggested in women wishing to retain their fertility. Here we can see the advantages and disadvantages of all these methods. Again, it's not an easy puzzle to solve, and individualization is very important, and consultation by a team of doctors specialized in both fertility and surgery. Okay, here we can see that myomectomy is superior with regard to other options, with regards to the outcomes, to the fertility outcomes, and of course, minimally invasive hysteroscopy or laparoscopy is by far more superior than the traditional approaches. So that's a piece of good news for our patients. Robotic surgery is the state of the art, newest technology, has been around for almost 20 years. Started in the US. In the last 5 years, it has become even more widely available in Europe, and now it's available in many centers, including ours. And it has big advantages with regards to the alternative, which is the conventional laparoscopy, especially with regards to myoma surgery on patients wishing to retain their fertility. And this is a review. It has been an amazing work done by our team. We're very proud of this. It hasn't been published yet. It's under review. So hopefully we should be able to share with you the outcomes and the advantages of robotic myomectomy over conventional laparoscopic surgery. And that is with regards to both the pregnancy rates, the miscarriage rates, the mean time to conception, and the live birth rates. So watch the space for the publication. Hopefully, it should be out in the next couple of months. Of course, hysteroscopic management is also important when we're talking about congenital anomalies. And thankfully, in the last 20 years, many centers, including ours, have acquired significant experience in successfully managing those debilitating conditions if left untreated. So here we can see the advantages of hysteroscopic metroplasty. Now, take-home messages so that I can give you some time for questions. Firstly, any anomalies of the uterus may have an impact on fertility. They may cause a plethora of clinical manifestations. They are often underlying cause of infertility. I've had dozens of cases in which patients were referred to me, to our team, having had all comprehensive and sophisticated recurrent miscarriage investigations, and they had missed the fact that they were suffering from either submucous fibroids blocking most of the uterine cavity, or congenital anomalies that were undiagnosed and untreated. Surgical treatment is the most effective therapeutic option, especially with regards to fertility patients. And thankfully, minimally invasive solutions are available, are here to stay, and they provide amazing results with regards not only to fertility, but also to the quality of life for patients. Here you can see some literature that we use for this presentation. I'm deeply sorry for the delay. I hope I will manage to catch up with some questions, and thank you so much for listening. And before I go, thanks again to my team for preparing this talk, and in particular, Dr. Manos Xidias, our research fellow, who's put in amazing work. Thank you very much.
So much indeed, Dr. Tsakos. I'm glad that in the end we were able to listen to your presentation. You were able to join us. This is what's important. And right now, your favorite time, Q&A time. There are some questions ready, but if you have some more, if you wish to ask anything, this is your time. Dr. Tsakos is right here for you. Let's have a look, okay? Because the first question is quite a long question. So let's see. This is a question from Jane. I had one fibroid which was felt to not to be supracausal, so was advised to ignore it. I did 9 transfers, all euploid, no implantation in, and had 3 years with no implantation trying naturally. I then developed a submucosal fibroid and surgery was recommended. The surgeon removed both through abdominal myectomy. They were very small, 2 centimeters, 1 centimeter. The surgeon said if I didn't have implantation failure, he wouldn't have removed them, but based on the histology, they were both submucosal. I have had 1 transfer since euploid again, which was a chemical pregnancy. Could the fibroids be the cause of the implantation failure? We have a full HLA DQA1 match, which is a controversial diagnosis, and don't know if I need to consider myself as reset after the fibroid removal, or if they didn't impact the failure and that things will never work. Anything you can advise?
Yeah. Hi, Jane. I'm really sorry to hear your story, and I mean, congratulations for persevering and for your strength to keep going. If I can make a couple of comments, I mean, with no offense to anyone, I'm a little surprised that for a 2 centimeter and 1 centimeter fibroid submucosal, you had an abdominal myomectomy. I mean, abdominal myomectomy means that your uterus has been incised, has been opened up and stitched together. This is probably not the best thing that can happen to anyone's uterus. So since that is done, I mean, gold standard to my mind for submucous myomas is hysteroscopic management, or at least hysteroscopic resection of the submucous component if there is a myometrial component as well. Anyway, now, I mean, my suggestion would be to evaluate the uterine cavity once again by means, start with a hysteroscopy, with just a standard hysteroscopy, just to ensure that the uterine cavity is normal, especially after the abdominal surgery you've had, and maybe also have some sort of HSG, some sort of assessment of the uterine cavity as well as the tubes, because one of the consequences of abdominal surgery may have been damage of the tubes in terms of adhesions or more importantly hydrosalpinges. So before I had another transfer, I would like to ensure that you don't suffer from hydrosalpinges, and this can be diagnosed by a standard X-ray HSG. And also I would like to ensure that your uterine cavity is normal or very near normal by means of a hysteroscopy.
Right. Thank you so much. And let's have a look. Jane has some comments. I will show you those right here. He couldn't get them out by hysteroscopy, as when infused with fluid, they disappeared into the lining as they were small. Instead, lab, he wouldn't be able to see them. And one more thing, I have had saline scan and HSG since both were fine.
Congratulations for that result. I would still have a hysteroscopy before another embryo transfer. to be honest.
Mm-hmm.
The accuracy, the value of hysteroscopy is much superior to saline or HSG when we're checking the uterine cavity. And I presume that since they were not impinging into the uterine cavity, they were just submucosal, they were not protruding. So hopefully the uterine cavity has not been breached through the surgery, and hopefully the hysteroscopy will be normal, but please have it done.
As you can see, HSG was done by interventional, radiophysiology, and Asherman specialist said no need for hysteroscopy.
Sure. I would still suggest that a hysteroscopy is the gold standard. I mean, this is probably going to be your last embryo transfer. You've been through so much. I think there's no doubt that the accuracy of a hysteroscopy is much higher than any imaging technique. And also, maybe by doing this, you will ensure that the cervix is normal. There's no adhesions in the cervix. Maybe with a small dilatation that will facilitate the embryo transfer, and maybe you can do a small scratching of the uterine cavity and obtain some histology, and why not a microbiome testing in order to get as much information as possible before you proceed to the transfer. Well, as I said, this is my opinion.
Of course.
See if it's useful or not. That's entirely up to you.
Of course, and so already done many times, but of course that's 6 biopsies. Yes, Jane has added that 6 biopsies were already performed.
Yeah.
I hope that helps, Jane. Of course, best of luck. You've been through a lot, but of course we are hoping that you will be able to get the positive result as well. Okay, if you have any follow-ups, of course, you know what to do. Let's go to the next patient, to the next question that we have here. Please, will myomectomy cause scarring? I had a failed frozen embryo transfer, donor transfer, and was advised to remove 6 centimeters subserosal fibroids.
Okay, I mean, there's no surgery without scarring. Okay, so that's for sure. The question is, what's the benefit ratio? 6 centimeter tumor is a pretty big tumor, although it's usually benign, and although a subserous myoma in theory doesn't really affect an awful lot of fertility. Having said that, a subserous myoma could cause complication, either within the pregnancy or outside of pregnancy. In case of pregnancy, it would probably grow, it would probably double in size and become a 12 centimeter fibroid. So I would definitely have surgery for that. And the preferred option is always, at the moment, the gold standard seems to be robotic surgery, but even laparoscopic, conventional laparoscopic surgery could be an option in experienced hands. So I would definitely suggest surgery in your case.
Thank you, Sei, for your question.
And sorry, let me add that when I say surgery, I always, by default, in the last maybe 10 or 15 years, by default, when I say surgery, I mean minimal access surgery. Okay, I mean, I think abdominal surgery has probably no place in fertility care, in fertility management in nowadays. I think that there's no question about open surgery for benign fertility-related disease of the females. Thankfully, conventional laparoscopy has evolved amazingly in the last 20, 25 years, and we reserve the robotic surgery for more complex cases. So by default, when I refer to surgery, I always refer to minimal access and never to open surgery.
All right, thank you so much. And as you can see, there's thank you from our patient for you right here. Let's have a look. There are some more questions coming up. The next one is here. I just had an egg retrieval cycle where unfortunately I ovulated just before retrieval and my right ovary was not visualized through ultrasound, probably due to my multiple fibroids. There's no submucosal fibroid. I was stimulated for 13 days before the 3 follicles on the visualized ovary grew to desired size. I have been advised to consider removing the fibroids to give better follicle growth and visualization in future IVF cycle. What is your opinion?
Sure. My opinion is very straightforward. I mean, one of the challenges at the moment for the patients is that most IVF doctors these days, they're not minimal access surgeons. They're not trained in surgery. So when you're a hammer, you always see nails. So unfortunately, the expertise of a surgeon, usually they don't cohabit in the same room with the expertise of a fertility specialist. So in general, in my mind, if there's a big fibroid, and a big fibroid is a fibroid more than 3.5, 4 centimeters. Don't forget that the normal uterus size diameter is about 4 to 5 centimeters. So for a medium to a big fibroid, for multiple fibroids, or for fibroids within or close to the uterine cavity, or for fast-growing fibroids, multiple fibroids obstructing the ovarian view, the indication surgery. Also, please do not forget, I don't want to scare anyone. 22 size. I mean, size of uterus is 22 weeks. So, by definition, you need surgery. By definition, you need robotic surgery. You may need 2 procedures, because sometimes with a 22-week size uterus means that your uterus is up to the umbilicus and even a little bit above. So that is the football I was referring to in my lecture. So definitely surgery. This is for your health and also for your reproductive health. And you may require 2-step surgery. I mean, sometimes, I've had a few cases where even with Da Vinci robotic surgery, there were so many fibroids that it was virtually impossible to be removed in one procedure. And if that was done, the procedure would take very near 6, 7, 8 hours, and we don't want that. So, I was saying that, and please do not forget the chance of malignancy. It's not common to have malignancy, not common at all, but it happens. I see it about once a year, and sometimes with fibroids that perhaps they don't even look very suspicious. I mean, the most recent case was a couple of years ago on a young lady in her very early 40s with a myoma of 4 centimeters. Had a little bit of Doppler anomaly, had a little bit of irregular periods, a little bit of heavy bleeding, nothing serious. Done a hysteroscopy and biopsy on her, and that was a sarcoma. The lady had radical surgery, and then, she's still considering, to become a mother through surrogacy. So let's not forget the risk of malignancy. I mean, fibroids are benign tumor until proven otherwise. And always be skeptical about big multiple fibroids. Always be skeptical about fibroids that grow back after surgery, with fibroids with lots of vessels, lots of Doppler identified vessels and all that. Now, Yetunde, I can see your low AMH and 40 years old. Yeah, of course. I mean, at 40 years old, it is normal to have low AMH, but I think with a 22-week size uterus, I don't think you should get pregnant, either naturally or via IVF. I think you should sort your uterus out first, and then if this uterus is deemed to be safely impregnated, then go ahead. Otherwise, consider other options. Let's not forget that fibroids can be a debilitating disease. I mean, a little bit like endometriosis. And when we're dealing with serious fibroids, I mean, put it this way: there's 3 types of fibroids. They are the mild case, in which case there is perhaps a small fibroid of 2 centimeters away from the uterine cavity, or maybe 2.5, or maybe two fibroids of 2 centimeters away from the cavity, which is fine. Perhaps we can ignore them. We can do 1 or 2 embryo transfers and then see what happens. The majority of patients would get pregnant. Those fibroids will grow. They will double in size in pregnancy, but invariably they will produce no problems whatsoever. And then we have the medium case, in which it's a little bit more tricky. We have perhaps 1 fibroid at 3.5 or 4 centimeters. perhaps away from the cavity or even close to the cavity, not quite within the cavity. So, some people would say leave them, usually the fertility specialists, some people would say remove them, usually the minimal access surgeons. And of course, for patients, it's easier to accept. It's more convenient for them to sit on them and follow the route of ignoring them, which could be fine for some patients as long as they're aware that the chance of implantation, the chance of successful IVF may be reduced by a factor of maybe 30 to 50% because of the effect of those fibroids, of the medium-sized 3-centimeter fibroid on the implantation. And as long as they understand that the miscarriage rate may be a little bit higher, and as long as they understand that even if everything goes well, the 3.5 centimeters would grow on to become 8 or 9 centimeters in pregnancy, and it may produce pain or bleeding in pregnancy, and it may lead to a cesarean section because of obstructing the outlet of the cervix, and they may understand that a cesarean section may be a complicated cesarean section if there is a fibroid of 3.5 that has grown up to 9 centimeters. So our patients need to be aware of that, and I'm afraid many of them aren't, and they aren't because it's our fault. I think it's our doctor's fault. It's the doctor's fault. It's our fault. Sometimes it's the system's fault. I'll never forget a relative of mine, a very close relative of mine, who flew from the other side of the Atlantic. I'm not going to define it more. To have IVF in her honeymoon. During her honeymoon, she came to me, I repeat, a relative of mine, and only to discover that she had a 10-centimeter fibroid. And I said, I'm terribly sorry. I cannot do IVF. Since you're here for the honeymoon, how about doing robotic surgery to remove it? And she said, no, I'm not going to spoil my honeymoon. I'll go back and see what happens. So she went back, North America. I'm not going to define more. And basically all the fertility doctors said, oh, what's wrong with you? 10-centimeter fibroid, the uterus is okay. The endometrial cavity is a little bit Y-shaped, but never mind. She had IVF. She had a terrible pregnancy. Terrible complications, terrible pains. She spent 9 months in bed. She was lucky. She was blessed. She was alive at the end of it. She kept her uterus. The baby was born. But the lady suffered major consequences following birth and all that. So unfortunately, I repeat that, it's not just the doctors, but sometimes the system as well, the health system of countries, of various countries all over the world, doesn't consider a 4, 5, 6, 7 centimeter fibroid an indication for surgery, which is a different ballgame altogether. And then you have those are the medium cases. And then you have the straightforward cases with large fibroids or growing fibroids. The first thing I want to rule out is malignancy. And definitely one of the reasons why I want to operate on them is because, the sooner I get rid of them, the better for the patient. The smaller the scar, the smaller the impact on their general health, and the smaller the impact on the quality of life, and also the impact on their uterus.
All right. Thank you so much, Dr. Tsakos, for adding this. This is really complicated. It's not black and white, unfortunately, right? All right. There are 3 questions left. Let's have a look. If you have more questions, go ahead. This is the final call for those questions. And the question is, if the uterine cavity was breached during open myomectomy, does this mean that there would be implantation failure after then?
I don't know. Maybe is the answer. I mean, the best person to talk to is the person who did the surgery for you. And the best way to find out is by having a standard HSG and also hysteroscopy. If these are normal, then you can just go ahead. As simple as that. You can just go ahead.
All right. Again, thanks so much. And let's have a look. Anna would like to know, I don't have myoma of a fibroid, but I do have a small endometrial polyp of 1 centimeter. Can this affect fertility? I needed to ask.
Oh, Anna, thank you so much. Polyps and myomas, they're just first cousins. And unless you remove this polyp, you will not know if it's a polyp or a fibroid polyp. So in either case, anything, we don't like anything at all within the uterine cavity. So 1 centimeter polyp should be removed by hysteroscopy. That should be a straightforward procedure in the hands of an experienced surgeon with the use of high-tech equipment. It's a day case surgery with minimal implication on your everyday life and quality of life. And that should definitely affect fertility. And the suggestion is not only remove it prior to attempting fertility efforts, but do not get pregnant with it in situ, because the chance of that creating either a failed implantation or a miscarriage is fairly high.
All right. Again, thanks so much. Marina, we will go to your question. Sorry, I missed it, but here it is, of course. I have a subcutaneous myoma which was partly removed by partial curettage in a hysteroscopy. The doctor said now I am ready for transfers, but I wonder if there may be still something in the uterine surface impeding on implantation. Is curettage effective in the case of subcutaneous fibroid? And thanks a lot.
Well, it depends again. I mean, in my mind, curettage is mechanical curettage, and it's not effective in removing a fibroid or polyp or anything at all within the uterine cavity. And the contradiction in terms here is that although with hysteroscopy we visualize the uterus, if we do a curettage after the hysteroscopy, that's a blind procedure. And so I'm not a big fan of curettage at all, to be honest. Not only in fertility, but even in women with no fertility issues who just want to get rid of a polyp or a submucous myoma. The gold standard at the moment is operative hysteroscopy, which means that we visualize and at the same time we operate with the use of electrical energy. We used to use laser. Some people still do it. I think it's electrical energy is equally effective, and of course with great care not to damage the endometrium. And now in the last few years we also have mechanical energy, but also in the context of operative hysteroscopy. So I see and treat. I don't see and then try to curettage blindly. In either case, in your case, I would suggest two things, straightforward: a high resolution ultrasound in order to map that remaining tissue, to map and find out through the ultrasound. The high resolution 3D ultrasound on a good machine would show whether this myoma is within the cavity, is on the border of the cavity, or outside the cavity and within the muscle of the uterus. But I would always, I repeat that, I would always double that with the diagnostic hysteroscopy. May I stress here that the diagnostic hysteroscopy is not surgery. It's very straightforward. It could be done in the outpatients. It could be flexible without anesthetic at all, or it could be a standard hysteroscopy with very mild sedation, or with no anesthesia at all, or with slight local anesthesia. So it's not, it's not a big deal. It's a diagnostic tool, very quick, very safe, very effective, in order to ensure that the endometrium is normal. I mean, may I say this here? I've said it in various webinars in the past as well. If you consider the complexity, the implications, the cost, the fuss, the stress, everything of fertility investigation and treatment, including IVF, adding a hysteroscopy, I don't think it makes a huge difference. I mean, it's a very, very small add-on, which is fairly inexpensive, fairly straightforward, but it gives us amazing information about not only about the uterus, but also about the cervix and about factors that may reduce the chance of success of IVF. I mean, or of natural fertility. I mean, I know there are some colleagues, and I've had amazing theories about hysteroscopy we should not touch the uterus, and the uterus is a holy grail, and blah blah. And if we interfere with this, something's going to happen. I don't think that I agree with this after 30 plus years in the field, and I don't think there's any scientific evidence to support that. And may I add here, and that has also to do a little bit with age. I mean, think of the uterus as an organ that's functioning from the start of the periods, which is roughly the age of maybe 12 or 13. So by the time a lady is 35 plus, that organ has been functioning for more than, 17, 18 years. So if you multiply that by 12 months, that's in the hundreds of cycles. So some of those cycles go wrong. Okay, so there's no proper ovulation, perhaps, there's no proper shedding of the endometrium, there's other mechanisms. So there's a lot of reasons why an endometrium of a woman over the age of 35 especially is likely to have some sort of pathology. And especially when we suspect that pathology, when we see it on the scan, I can't see any reason why we should not be 100% sure that it's normal.
Brilliant again. Thank you so much indeed. There are like 2 questions left. We will be finishing. And the question is regarding fibroid surgery, robotic fibroid surgery, I might add. I didn't realize this was even an option when I was treated in the UK. And what is the cost of that robotic surgery?
Sure. Yeah. Hi, Jen. Well, I'm sorry, although I'm British myself and UK trained and all that, and I'm a huge supporter of the British system. Unfortunately, the Brits have been a little bit slow in picking up Da Vinci. Perhaps they were very good in laparoscopy. Maybe that's why. And this has been the case throughout Europe, maybe. But now robotic surgery in the last 5 years has been the gold standard in the Western world, at least. In England, it was a little bit slower, but in the last 2 to 3 years, there's been amazing shift towards robotic surgery. Now, the cost, of course, there's quite a lot of cost involved. Depends on the type of surgery, depends on some patient characteristics, depends on the duration of the surgery we do and all that. By all means, if you like to send an individual email to our clinic and send us some details about your case, we should be able to quote a cost for you. But generally, in Greece, thankfully until now, the costs are much less compared to the UK, so significantly less than the UK, and hugely significantly less compared to the US.
Of course. Thank you so much. And thank you for your question as well, Jane. Might be our final question, although I see someone is typing. So if you have more questions, go ahead, type those in. So as you can see, of all fibroids, or 3 fibroids, 1 centimeter need to remove.
Probably not is the answer, Nicole. However, I would be a little bit skeptical with regards to their location. So I would be very straightforward. If they're away from the cavity, they don't need to be removed at all. If they're close to the cavity but not touching or not protruding through the cavity, they're probably not worth removing either. But even if one fibroid, even ½ centimeter, 5 millimeters, is within the cavity, that has to be removed, in my opinion, or at least the component that's protruding into the cavity has to be removed for various reasons. One is that the chance of that growing is almost 100% in the next 3, 6, 9 months or so. And also in case of pregnancy, this will definitely grow and is very likely to cause problems, and most particularly bleeding and pregnancy complications. So probably not need to be removed as long as they're far away from the cavity, but keep a close eye on them.
Brilliant. Thanks so much, Nicole. Hope that helps. I do believe so. Straight answer. Someone is typing, so let's give it a second. Let's see if we have 1 more or 2 questions. If not, we will be finishing. Thanks, everyone, for your patience. And of course, I'm glad that we were able to be here and talk about this topic for sure. And I do believe it was already useful for you. I'm still waiting for a question. So let's, here it is actually. So let's have a look. Nadia has a question. I had transfer of 3 fresh embryos day 5 from egg donation. My progesterone level at day 5 after transfers was 57. 64 nanograms per millimeter, beta HCG 10.77. At the day 15 after transfer, beta HCG less than 5. The ultrasound shows an empty sac. Anything you can advise here?
Yeah, okay, Nadia, with all due respect, firstly, 3 day 5 embryos from egg donation is not something that most people would do, to be honest. It's probably, it's not a perfect example of good practice for various reasons. Most people, including our clinic, we wouldn't really transfer more than one blastocyst, and if we were seriously pushed, 2, but never 3. So that's a little bit of an issue. Now, progesterone levels after the transfer, it's a long discussion, but it's not a really, a means of either monitoring the cycle or finding out if we're doing good or if this is related to normal pregnancy or not, because it may depend on various factors. For example, when the sample was taken with regards to the intake of progesterone and all that. So I would probably disregard that. That's not helpful. Now, beta HCG of 10.7 again, doesn't say much because it's very low, of course. I don't know if what kind of supplementation you had in terms of luteal support and all that. So those figures, I don't think they can be very helpful. The day 15 after the transfer of less than 5 is definitely, unfortunately, negative result. So I'm sorry about the outcome, but if I were to give you messages that, I would be very skeptical about transferring more than 1 or 2 maximum blastocysts on an egg donation cycle. In actual fact, in Greece, it's illegal to transfer more than 2 embryos on an egg donation cycle. And so, I don't know if I've helped you, but, if any of you guys want some individual advice as a minor compensation for letting you wait for almost half an hour, this is our email. Please send us your individual questions. We may ask you to fill in a small questionnaire just to get an understanding of your situation. And my team and I would be more than delighted to offer you a free one-to-one Skype if you want some more advice. That's the least I can do, Caroline, for your amazing audience. And thank you so much for tonight.
Thank you so much indeed. And as you can see, there's a link, there is an email address in the chat you can see. So you can get in touch with Embryoclinic team, and I'm sure they will be happy to help you. And I'm sorry, but there's one more question. Can we still take it? It's like a short question.
Yeah, go ahead.
Is there like a waiting time when it comes to hysteroscopy at Embryoclinic?
Oh, Anna, yes and no. It's a little bit tricky to get onto the system, but once you do, then things are very quick. Basically, if I can give you some ideas, now we have some slots for May, for initial consultations, and usually we add in a hysteroscopy if it's indicated. It can be done during the initial consultation. So, it's about 1 month at the moment. Okay. Thanks a lot. I think we can still take one last. Yeah, well, sorry. With regards to cost, I didn't answer that. I'm not very familiar with costs. It's not it's not very expensive, but by all means, depends on whether it's diagnostic or operative, and depends on whether it's done within Embryoclinic or whether it requires the hospital that we work at, depending on the complexity. So please send us an email and indicate a few factors about your case, and we should be able to give you full quote. Brilliant. Thanks a lot indeed. Remember, you can use the email address, and that is in the chat. And Rachel has the final question. I have 2 failed IUIs last year, and I have had a transcervical resection of fibroids 2 weeks ago, where 2 fibroids were removed, 5 centimeters subserosal and 2 centimeters submucosal, which were close to the cavity and had to be removed prior to frozen embryo transfer. I have a follow-up appointment at the beginning of next month, where the doctor mentioned that I will have a saline uterine ultrasound. Should I also ask for hysteroscopy? Yes, please. Yes, I mean, put it this way. Hysteroscopy is the gold standard. I mean, that's undisputable. So, yeah, I mean, a quick diagnosis. I mean, if I do operative hysteroscopy, anything more than just perhaps a small polyp with a small base and all that, I always like to have another look if possible. That will give you the reassurance and also give your doctor the reassurance that everything is normal. And also it will give us an indication of the healing process. I mean, the healing process is something that it cannot be picked up 100% with a saline ultrasound. Now, of course, another factor is cost effectiveness. I mean, if there's a huge difference in cost, and if your doctor is confident, then yeah, saline ultrasound would be an option, but only in terms of saving costs. I mean, in terms of actual medical grounds, I think the value of hysteroscopy is much superior.
And with that, we will end this tonight, the Q&A session. As you can see, many things are coming up your way. As always, brilliant presentation. Couldn't agree more. It was a great session. So I am really happy that in the end we were able to just make it here, and we're able to answer your questions. Dr. Tsakos, it's always lovely to have you. Anything else you would like to add before we end this for today?
I'm very happy and proud for the European Fertility Society and this initiative. For me, this is one of the moments where I feel a real doctor, helping people I've never met and probably I will never meet again, and trying to, to add in a little grain of sand into their knowledge and experience. And I never stop admiring those amazing people who keep trying and keep going. And it's amazing how much strength I get from you guys because I know how difficult it is. And thank you for sharing your thoughts and sharing your anxieties. And I hope I have helped even a little bit. Thank you so much.
I'm sure you did, as always, of course. Dr. Tsakos, thank you so much indeed. I just want to add that we will be back, of course, in 2 weeks' time. There is another webinar with Dr. Stefania Rodriguez, another topic, PRP this time. But let me just also mention that Dr. Tsakos will be back on the 27th. We will have another webinar on the 27th of April. So I'm looking forward to it already. We will talk about hysteroscopy as well, right, Dr. Tsakos? So stay tuned, and you can register on our website. There is a link already, so go ahead, take a look at it and register, and I hope to see you there as well. Thanks a lot, everyone. Enjoy your evening, and we will be back very soon. Take care. Bye.